So I'll be talking on IVUS co-registration tips and real-time guidance. These are my disclosures. And before I get into my talk, let me show you some of the data which was gathered by NIC and presented, I think, a month ago. This was the use and utility of IVUS during PCI in India. It was 1.96% in 2022 to 6.3% in 2023. So really a massive jump, but still it's a far cry for IVUS penetrating into normal practices. And coming to physiology, it is less than 2%. And when we talk about the IVUS facilities, this is majority of the times it's the Boston's IVUS being used, 75 to 80%, and rest 15% the Philips and other IVUS are being used in India. So why I'm presenting this data? Because the co-registration, which is available with Philips, and that is commercially available, used in multiple places. But in India, the maximum penetration is of Boston's, and the AV system of Boston for co-registration is still awaited. So, and that's why some of my slides will be from internet, and I'll be showing some of these slides from the internet. So to begin with, this is a patient of 62 years old, male, diabetic, hypertensive, presented with chest pain on minimal exertion for last 3 months. He had a bypass surgery done 11 years back. Lima was given to LED and SVG was given to PDA. And now he has refractory symptoms, and this is the angiogram which we can see LED is CTO, and Lima is not working. And this sole, I think, surviving graft which is filling the RCA as well as the LED. And then through wire escalation, LED, the disease was negotiated. And this was after the balloon dilatation. You can see here how diffuse the LED lesion is, LED vessel is. And when we go through the imaging, all these markers, red markers, are all approximation. These are not exactly co-registration, and there are chances of errors, and that could be 1 millimeter, 2 millimeter, and even can more. It can lead to geographic miss, and it requires more of injections and little approximation rather than precise landing zones and precise nailing the entire vessel with proper stenting. And that is where co-registration comes into the picture. We do get this kind of results with good MSAs, but still precision is a little bit compromised. And if we can get something like this, cursor moving down and up, and you're getting the IVUS image co-registered, then your results will be much better. So what all we can sync and co-register, we can do IVUS with fluorosyncing, we can do physiology with fluorosyncing, we can do imaging, and as well as physiologic with syncing with fluoro. And these are not only the kind of 1 or 2 studies on algorithms. It has been used, validated, improved, and now all the systems which are there, they have been thoroughly validated, and the margin of errors are really, really less. I will show you some of the data here. So let's look at this vessel. It's a diffusely diseased vessel with a LED, mid-LED stent, and this is co-registered on IVUS. And how we exactly see that co-registration is perfect. You can see this yellow dot here, and you can see the septal, which is rising just proximal to or at just the yellow dot, and you can see this septal rising here. And then you can also see the long axis view, and then you can get to know that your co-registration is good, and you can reconfirm it while getting this yellow dot here, pulling back, then the IVUS, looking at the IVUS and the fluoro, and you can see the yellow again corresponding to the side branch, and this side branch is looking up here. So this is how we kind of test and confirm the co-registration, so that our kind of interpretation and finally the treatment becomes more precise. So how do we do that? We give generous nitrates and vasodilatation agents. Fluoroscopy setting has to be at 30 frames per second, not at 15 or 10, which we used in CTOs, and sometimes when we try to go at lower radiation, it has to be 30 frames per second. Guiding catheter tip, entire wire inside the artery and the vessel to be seen without panning. And then these are the kind of views which we take for the LAD. It's mostly the epicranial for co-registering. epicaudal for circumflex, and allocranial for RCAs. And then we do IVUS pullback at 1 millimeter per second till it reaches the guide. Then we can stop on IVUS, comma fluoro, and then we can co-register and look at the images. So this patient had mid-LAD stent, which was there, and which shows a MLA of 3.68, distal reference of 3.27, and the proximal, where you can see a large plaque there, is more than 70% plaque, and MLA of 3.03. And then we can see with co-registration exactly matching up the IVUS measurements as well as your co-registered fluoro measurements. Then we can deploy the stent, and then we can, since we have a common reference, ready reference with us, we can look at the MSAs, distal reference, and the proximal reference. And we all know the kind of the criteria which we assume that our stent expansion is appropriate when we get a kind of when we have a vessel of less than 9 millimeter square, and if we get an MSA which is 90% of average proximal and distal reference lumen, or 100% of smallest, that is distal reference, or a vessel which is more than 9 millimeter square, we need to get a 80% of average proximal and distal reference lumen, or 90% of the smallest or the distal reference. So we have a kind of a ready reference with MSAs available. We can quickly go through that and make an idea that our stenting is perfect or not. So this is how the co-registration helps us, and it helps us immensely in reducing the geographical misses. So this is again, we can see here the co-registered lens segment to IVUS and the fluoro, and they are matching up, and we have a kind of, we can also match our MSAs with this. If we have post-dilated with 3.5, we should get at least 8 millimeter square. If it is 4O balloon, it should be 10 millimeter square. It is 4.5 in, especially in left mains we do, and we should getting a more than 12 millimeter square MSAs. What about adding up some of the another features like having check on cherries, cherries on cake? So you can see if you co-register physiology as well as the IVUS, you can have a better precision and better understanding of entire problems. And you can see the dots, and when we talk about co-registering and tandem and diffuse lesions, there's always IFR which gets more kind of preference over FFR, because in FFR, two adjacent lesions can interfere when there is a stage of hyperemia. But IFRs are localized. These the resting flows, the adjacent lesions are not interfered, and you get precise IFRs and step-ups where there is a maximum hindrance of the flow. And you can see here there is in the diffuse lesions, the FFR goes down gradually and gradually as two lesions are interacting amongst themselves. But in IFR, you can exactly pinpoint where it's exactly dropping the IFRs and the pressure drops. And that is where you can see the lesion 3, there is a drop in IFR is lesser, but when you go up 2, there is again a drop, but as lesion 1 and 2, the drops are maximum. Probably these are the lesions which needs to be fixed up. And this can be co-registered as well as with IVUS, and you get a kind of better interpretation and better kind of information. And finally, we are all looking at AV Vigo system of Boston to be available in India, so that maximum 70-80% of Indian cath labs are using Boston. And once this will be available, this co-registration and all will come into practice with in the Indian scenario. And finally, this is my last slide. What does it offer? We can do a PCI, we can do IFR pullback, we can see exactly where is the problem, we can do an IVUS, which we do regularly. And what extra it is offering? It's offering us precision. It's offering us, it enables us to minimize the time, radiation, and the contrast. It minimizes the errors, and finally, it boosts the confidence of patients as well as the patient going home. Thank you so much for the patient hearing.